Good morning, everyone. The topic for today's lecture is the bionator. This lecture includes history, introduction, philosophy of the bionator therapy, construction bite, indications and contraindications of bionator, the types of bionator, terminologies used in trimming of the bionator, trimming of bionator, advantages and disadvantages, modifications of bionator appliance, cases treated with bionator appliance, bionator and temporomandibular joint cases, conclusion and references. Balters in 1960 developed the original appliance, whereas Bimler at the same time in 1964 was working with a similar appliance called as the skeletonized activator. Although the theoretic basis of the Balter's appliance are based on the Robin, Anderson and Hoppel concept, it is different from that of the activator. How is it different from that of the activator? The bulkiness of the activator have deterred many clinicians in using the appliance to attain greatest growth potential. Hence, to avoid this bulkiness in the activator, the acrylic portion was reduced from the anterior regions of the palate, such that only lateral extensions posteriorly were remaining. So this appliance could be worn day and night except during meals, and the palate was free for the proprioception from the tongue. In normal scenarios, unfavorable external and internal muscle forces leads to undesirable restrictive effects on the dentition and supporting structures. The bionator has a component of a buccal extension that will restrict these unwanted forces. And because of lesser bulk, the constant wear of the appliance resulted in a more rapid sagittal adjustment of the musculature and forward mandibular posture, because the mandible will only retract during eating and rest all the time the mandible is in a protruded position. Philosophy. Balter believed that the equilibrium between the tongue and the circumoral muscle is required for the proper space of the dental arch and intercuspation. For Balter, the tongue was the most important factor in the treatment, or the center of the reflex activity of the oral cavity. So in this diagram we can see the muscles from the outer buccinator mechanism and the orbicularis oris opposed by the muscle from the tongue inside. Balter believed that the role of the tongue is decisive. According to a research done by Winders in 1958, tongue could exert 3 to 4 times more pressure on the dentition as does the labial and the buccal musculature. The principle of the bionator is not to activate the muscle, but to modulate the muscle activity, thereby enhancing the normal development of inherent growth pattern. Now the construction bite of the bionator. The bite cannot be opened vertically much in a bionator. It should be positioned in an edge-to-edge relationship. If the overjet is too large, the mandibular posturing can be done in a step-by-step manner, but will still not open the bite. If in any case a high construction bite is taken, then it could lead to two of the following problems. First, a bite could impair the tongue function and the patient could acquire a tongue thirst habit. The myotactic reflex activity works with the isometric muscle contraction, and the loose appliance works with the kinetic energy, since the bite is taken not beyond the postural rest position. Unlike the Harvold-Woodside activator, where the viscoelastic properties of the muscle and the soft tissue and the stretch reflex response were employed in the vertical dimension. Now we'll see what are the indications of bionator therapy. It can be indicated in class 2 division 1 malocclusion, in class 3 malocclusion, and in the open bite cases. In class 2 division 1 malocclusion, it can be indicated in cases where there are well aligned dental arches, where the mandible is in a posterior position, that is functional retrusion, skeletal discrepancy is not too severe, and the labial tipping of the upper incisor is evident. However, it is contraindicated in cases where there is a class 2 relationship caused by maxillary prognathism in a vertical growth pattern, and in cases where there is lower lingual procubency. Now there are various types of bionator. The three basic types are the standard bionator, the open bite bionator, or a class 3 or a reversed bionator. Then in the standard bionator, it is given in cases of class 2 division 1 malocclusion, where there is a lower lingual acrylic extending from the distalmost molar to the distalmost molar on the opposite side, and the upper posterior extensions of the upper acrylic, such that these two acrylic are in contact with each other interocclusally with the correct construction bite relationship. The tongue function is controlled by an edge-to-edge incisal contact relationship that leaves no space for the thirsting activity. Now the function and posture of the lips, cheek and tongue, they are guided by the two wire components. The first one is the labial bow with the buccal extension, and the second one is the palatal bar. So the palatal bar is made up of 1.2 mm hard stainless steel wire and extending from the edges of the lingual acrylic frange in the middle of the deciduous first molar. After emerging from the acrylic, it lies about 1 mm away from the palatal mucosa. It runs distally such that it forms a loop which is posteriorly directed. This cross palatal bar has two main functions. First, to stabilize the appliance, and second, it orients the tongue in a much more downward and a forward direction to allow for the correction of class 2 division 1 malocclusion. So the forward orientation of the tongue, according to Barter, is accomplished by stimulating its dorsal surface with the posterior curve of the palatal bar. Then the second wire component is a labial bow of 0.9 mm hard stainless steel wire, which begins above the contact point between the canine and the deciduous upper first molar. It then runs vertically, making a rounded 90-degree bend to the distal of the canine along the middle thirds of the upper posterior teeth, and extends as far as the embrasure between the second deciduous molar and the permanent first molar. From here, a sharp angle is extended From here, a gentle curve down and forward, downward and forward. It runs anteriorly at about the same position with respect to the buccal surface of the lower posterior teeth as far as the lower canine. After it has reached the lower canine, it extends obliquely upwards towards the upper canine and extends to the canine on the opposite side. It ends in a mirror image formed on the opposite side and inserts into the acrylic. Then the open bite appliance. The open bite appliance is used to inhibit the abnormal posture and function of the tongue. The construction bite is taken as low as possible to prevent the tongue thirsting in between the upper and the lower incisors. Hence, to inhibit the tongue movement, two of its components plays a major role. The first one is the acrylic portion of the lower lingual part that extends upwards behind the upper incisor, making sure that it does not actively put pressure on the upper incisor. Hence also closing the space, the upper anterior space, without touching the upper teeth. And the second is the labial part of the bow that reminds the lip for the competency of seal. The palatal bar in this scenario has the same configuration as that of the standard bionator. However, its function is only for the stabilization of the appliance, and the wire runs approximately between the incisal edges of the upper and the lower incisors, acting as a reminder to the lips. Class 3 or reversed bionator. The class 3 or the reversed bionator is used to encourage the development of the maxilla. The construction bite in this scenario is taken in the most retruded position possible. Palatal bar configuration runs forward instead of posteriorly. Hence, the loop is as far anteriorly as possible up to the deciduous first molars or premolars. This will guide the tongue in a more posterior and upward direction, hence correcting the class 3 malocclusion, and the tongue is supposedly stimulated to remain in a retracted position in its proper functional space. The labial bow design in this scenario is that it runs in front of the lower incisor. It emerges from the acrylic in the same manner as that of the standard appliance, but the labial part runs along the lower incisor without the oblique bend up to the upper canines. There are various terminologies used in the trimming of the bionator appliance. These are articular plane, loading area, tooth bed, nose, and ledge. This plane extends from the cusp tips of the upper molar, premolar and canine up to the mesial margin of the central incisor, and it is parallel to that of the alar tragus line, which is an important assessment for the mode of trimming. Then there are areas which are devoid of acrylic. These are the unloading areas, and those areas in between the cusp that have acrylic are the loading areas. The tooth bed, some parts of the loading areas are trimmed away to the articular plane such that the acrylic surface prepared in this manner is called as a tooth bed. The noses are the finger-like projections located mesial to the molars. These noses play a very important role in the anchorage of the appliance and allow as an eruption guidance to the teeth. Now ledges, depending on the tooth movement desired, the appliance acrylic is trimmed and the nose is reduced. A reduced plastic extension placed only onto the occlusal third of the interdental area is called as a ledge. So the nose is mostly on the mesial margin of the first permanent molars, whereas the ledge is in between the premolars or the deciduous molars. After we have seen the various terminologies, we will see the trimming of the bionator. The anchorage of the bionator permits an anterior posturing of the mandible, which is determined by the construction bite. As on the activator, trimming of the occlusal surfaces of the bionator is essential to allow certain teeth to erupt, whereas hindering those teeth which are already erupted or up to the occlusion. So Balter's terminology refers to stimulation of eruption as unloading and prevention of eruption as loading or inhibition of growth. The appliance can be trimmed or ground periodically until the teeth reach the desired relationship with the articular plane. Because of the need to anchor the appliance, this procedure cannot be performed in all areas at the same time. Thus, periodic loading and unloading of the same area are necessary. This means the same tooth will function as an anchor first and then will later be reduced to allow for the eruption of the teeth. In this diagram, we can see in the first diagram, the unloading has been done, which will allow for the eruption of both upper and the lower molars, whereas in the second diagram, the unloading has been done on the lower molar, allowing only for the eruption of the lower molar. To allow extrusion of the posterior teeth, some acrylic is always left interdentally, forming the so-called tooth beds. The acrylic projection between the teeth are left untouched or replaced with self-cure acrylic, and in cases of open bite, it makes sure that the posterior teeth are fully loaded to allow for intrusion of the teeth. Now the anchorage of the appliance draws its anchorage from various regions. The first is the incisal margins of the lower incisors by extending the acrylic over the incisal margin as a cap. The loading areas where the cusp of the teeth fit into the respective groove in acrylic. Deciduous molars act as anchor teeth. Edentulous area as the premature loss of the deciduous molars. Noses and labial bow, which prevents the posterior displacement of the appliance. Now there are various advantages of bionator. As we have seen, it has a reduced bulk, hence can be worn day and night. The appliance also exerts a constant influence on the tongue and the perioral muscles because the screening effect of labial bow and its lateral extensions. Because unfavorable external and internal muscle forces are prevented from exerting undesirable and restrictive effects on the dentition and supporting structures for a longer time, the bionator action is much faster as compared to the activator. However, there are various disadvantages of the bionator appliance. The main disadvantage of the bionator lies in the difficulty of correctly managing it. The difficulty stems from the simultaneous requirement of stabilization of the appliance plus selective grinding for eruption guidance, that is for loading and for unloading. Normalization of function can occur only if the inherent growth pattern of the patient is normal in the first place, with no environmental influences to prevent accomplishment of that pattern. Then the clinical management of the bionator treatment. For maximal benefit effect, the bionator must be worn day and night by the patient, and it should be removed only during eating. The time interval between the office visits is 3 to 5 weeks, depending on the state of eruption of the teeth. Labial bow should be checked and ensured that it does not touch the teeth. Only if it does, it should be only touching lightly. The buccinator loops should be away from the deciduous first and the second molar area, but it should not irritate the cheek mucosa. And in the final stage, if the minor spaces are still open, the active retraction can be done with the help of the bow or the labial bow. Then, in accordance with the plan of anchorage and growth promotion, the loading and unloading of the acrylic can therefore be planned to allow to ensure if the tooth movement is to be stimulated or to be retarded. Any modifications that need to be performed should be first on the molars, second on the lower premolars, and third on the upper premolars. The correction takes place in the following sequence. The first phase of the treatment will allow for a rapid horizontal and vertical change in the mandibular position. The first and foremost change is in the muscular adaptation, that is shortening of the lateral pterygoid muscle. Articular and the dentoalveolar adaptation occur in the second stage following the neuromuscular adaptation. Now we'll see some of the modifications of the classic bionator plans. The first one is the acrylic body of the bionator is reduced in size, extending less along the alveolar process than in the original appliance, hence further reducing the bulk of the appliance. The second one is the change in the labial bow design. In the original appliance, there was only one labial bow with buccal extension, but in this case, the labial bow is in this situation, the labial bow two labial bows are used. The first one with the labial bow with the buccal extension, the upper labial bow, and the second is the lower single labial bow. Then the transparietal bar opens in a distal direction in the modification, which is different to that of the, which is actually opposite to that of the standard bionator appliance. Then the sagittal anchorage is reinforced with the wire spurs located mesial to the maxillary first molar or canine that will increase the sagittal anchorage. And the last one is the incorporation of the metal occlusal bite, and this is only given in cases where we need the correction of the deep bite cases. Now we'll discuss some of the cases treated with the bionator appliance. The first one being a 9-year-old male patient with a mild class 2 division 1, which is treated with bionator for a period of 1 year followed by retention, and the final cast is shown as the last image, and showing the correction of the class 2 division 1 malocclusion. Then the second is a 7-year-old patient with class 3 malocclusion treated with a reverse bionator appliance. The third scenario is a 8-year-old female patient complaining of open bite and treated with open bite appliance for a period of 6 months followed by the retention phase, and the intraoral photograph is taken post-treatment after the eruption of permanent second molars. Now we'll discuss the relationship of the bionator with the temporomandibular joint cases. The design of the appliance for this purpose is similar to that of the standard appliance, except the construction bite needed to move the mandible as forward. In this situation, the construction bite is taken such that the mandible is only moved up to a position where the overriding of the condyle onto the articular disc could be avoided. So wearing a bionator at night will tend to relax the muscle spasm, particularly in the lateral pterygoid muscle, and will relieve all the temporomandibular joint dysfunctions created also because of the clenching or the bruxism habit at night. Bionator therapy, along with local heat applications and muscle relaxants, can provide immediate relief to the temporomandibular joint patients. This is the article quoted in Angle Orthodontics, where a 20-year follow-up of functional treatment with bionator appliance, a retrospective dental cast analysis has been done, which shows that during the treatment, arch perimeter significantly increased but decreased in the long-term basis. Arch depths only slightly improved. Intermolar significantly increased during treatment. Lower intake canine distance remained fairly unchanged during the treatment. Lower incisor irregularity improved slightly during the treatment. And after treatment, sagittal molar relationship on both sides were improved. Overjet and overbite were reduced, and these significant changes remained stable long term. To conclude with, the bionator is effective in treating functional or mild skeletal class 2, class 3 or open bite malocclusions in the mixed and the transitional dentitions, provided that the appliance is chosen for a careful diagnostic study. It is made correctly and managed properly by proper loading and unloading different areas as indicated during the eruption of the premolars, and the patient complies in both the daytime and the nighttime wear. These are the references. Thank you.